So, Nick, I wondered if I could ask you to talk a little bit about particularly premature menopause, including surgical menopause, and what just because the more that this is kind of raised in the media, the more that people hear about it, the more we're hearing from women who perhaps have gone into an early menopause in the past and perhaps not had all the information they needed. And they're hearing lots of things about, kind of what the potential long-term effects of no hormone therapy is. And I wondered if you could talk about, particularly for those who go into a premature menopause for whatever reason, and those who go into a surgical menopause before the natural age of menopause, what the considerations should be about essentially looking after long-term health and how that can be achieved.
Well, we need to think about those conditions as we would about any hormone deficiency condition. An analogy would be loss of insulin in diabetics, for instance, or women who have an underactive thyroid. It is a genuine form of hormone replacement that women require, usually to maintain their quality of life, although some are lucky enough not to have too many symptoms, but also to prevent the long-term outcomes of an early menopause or premature menopause. So premature is before the age of 40, early before the age of 45. And the long-term outcomes that can occur if left untreated include an increased risk of osteoporosis, increased risk of cardiovascular disease, and also potentially an increased risk of dementia. But hormone therapy from, ideally as soon as the diagnosis is made through to at least the average age of the menopause, in theory, should restore that individual's risk profile where it would have been if they'd gone through the menopause at the natural age. Now, we've done some research through our registry to show that women who go through a surgical menopause actually can have more profound symptoms to begin with, because through loss of the ovaries, they lose their hormones more rapidly than women who go through what we call a spontaneous premature menopause or premature ovarian insufficiency, which is the sort of scientific term.
Mm-hmm.
So things like hot flushes and sweats, mood swings, cognitive problems, musculoskeletal aches and pains, vaginal symptoms can be much more acute and much more profound in those individuals. And I think it's imperative that if they can have hormone therapy, the women who have surgical menopause should get it immediately. Those women who go through spontaneous premature ovarian insufficiency and aren't particularly symptomatic sometimes need a little bit of time to get their sort of head around the diagnosis. It's a profound diagnosis. It obviously has profound fertility implications as well as hormonal
Complex, isn't it?
implications. Yes, and then they may want to take months or even a year or two before deciding whether to start hormone replacement. Whilst we do try to encourage, them to start as soon as possible, that's not to say that they're not going to derive benefit from starting later on.
Mm.
And even 5 to 10 years later on, there may well still be benefits. You don't miss that opportunity. People think once you've not given hormone therapy within the first few years of menopause that you can't positively affect bone density. Of course you can. You can actually increase bone density whatever age you start hormone therapy at. So, as you know, both conditions can have serious effects. And I think that one of the frustrating things is that it's been a bit of a taboo subject, really. Younger women, I think, are more reluctant to talk about, menopause. It's something that shouldn't be happening to them. It should be happening to mothers and grandmothers. And it's not the sort of thing that a lot of young women feel comfortable talking to their peers about. But I think that's where groups like the Daisy Network, for instance, which is a society that I'm a patron of, proudly a patron of, can provide, support, not just in terms of education, but also in terms of putting sufferers in touch with each other so that they can get information from each other within within groups, either groups of two or couples or larger groups. And yeah, it's just, we need to, along with the other aspects of menopause, we need to be, screaming this from the rooftops to say, this is a group of women that, should not be suffering in silence, and having a premature menopause will have an even more profound effect on this group than natural menopause has on an older age group.
Yeah. And Nick, what's your, you said, kind of starting it as early as possible, at least until the natural age of menopause. What's your thought on continuation of hormone replacement therapy after the natural age of menopause, specifically for those who had experienced a premature, or it could be surgical and premature, but what's your thoughts on the continuation of hormone replacement therapy? In fact, you might want to expand that out to everybody.
Well, look, I mean, I wouldn't, again, put a general rule on this. We try to individualize. We look at the benefits and risks that individual might get from continuing their hormone therapy, as we would in somebody with natural menopause. So, we'll look at their quality of life, their symptoms. Have they got ongoing hot flushes, sweats? Some do. Any ongoing mood problems, cognitive problems, vaginal problems, libido, all of these things take into account. Are there any risk factors, either cancers or heart or bone, etc., etc.? And we take all of that into consideration in deciding whether hormone therapy is continued. So we shouldn't put arbitrary limits on duration of use. And what the menopause societies are saying is that we should have at least an annual reevaluation of pros and cons of whether we continue with hormone therapy. And if there is a reason to continue, be it for quality of life, or be it because we're worried that somebody still has suboptimal bone density, then we're happy for them to continue with it, and we enable them to make an informed choice.
And Nick, does that continuation then continue to have an effect on long-term heart health, brain health, etc.?
Yes, as long as hormone therapy started within that window of opportunity, as we refer to it, which is usually within 10 years of the final menstrual period, although that refers to natural menopause, maybe even longer for women with premature menopause, then certainly the cardiovascular health, bone health, and possibly the cognitive health, although that's a little bit more of a controversial area, continues. The concern is where the wrong types of hormone therapy in the wrong dosage are started in too old an age group, and then you can potentially have a thrombotic effect, a stroke effect. But if you don't do what they did in WHI and give women in their 70s the same dose and combination of hormones as you do somebody in their 50s, then you tend not to run into those problems. The thing that we should be mindful of is that even with what we refer to as regulated bioidentical hormone therapies, there is still the potential for increased risk of breast cancer with long-term use. So that does have to be taken into consideration along with the potential benefits.
Okay, so that's great. That's really helpful.
Can I just also add one more thing?
Of course.
The risk of breast cancer for women with premature menopause using hormone therapy is no different to the general population of the same age group in whom their ovaries are working normally.
Yeah.
So there is not a reason to stop hormone therapy before the average age of menopause for breast cancer reasons, unless there is a specific problem, of course.
Yeah. Okay, so something that's sort of aligned to this is a question that we regularly get posed, and I have heard lots of sort of different answers to it, but I don't have a definitive answer, and you may not either. It might be individual. But particularly for those who have gone into a premature or surgical menopause, so premature obviously is early in their lives, but and surgical earlier than the natural age of menopause. One of the questions we regularly get asked is around concerns around bone health and whether or not there is a marker, as in, is there an estradiol level that needs to be achieved to provide protection for bone health? What's the answer to that?
Well, the answer is that I believe very strongly that every woman that goes through a premature, spontaneous or surgical menopause should have a baseline bone density scan. And then the bone density should be followed. And the frequency of the bone scans will depend on how worried we are about the risk of osteoporosis. John Studd showed that there is a dose-response effect as far as estrogen and bone density is concerned. But there are studies that show that even very low levels, very low doses and very low levels of estrogen can still be beneficial for bone health and bone density. Now, you may not get the same improvements in bone density at those low doses of hormone therapy. So there may only just be a stabilization of bone loss.
Right.
But just to give you an example, there was a study called the Menopause patch study, where they looked at 14 microgram patches, and it showed, some protection of bone density, even at the 14 microgram dose, where the standard dose, as you know, is around 50 micrograms. So yes, there is a dose response effect, but in order to best decide what the correct dose for that individual is and what level they should have, we should be following their bone density.
So it's more, so you would be looking more at the results of DEXA scans than you would looking for an estradiol level.
A certain estradiol level does not guarantee that bones will be adequately protected.
Okay.
Or that you will see an improvement. And there are, for whatever reason, and we don't fully understand this, but there are women who appear to have reasonable estrogen levels for some reason who continue to lose bone density. And that's where we then need to think about other bone sparing options or increasing the doses. But we cannot just rely on estrogen levels.
And in those premature menopause women, is there should they be having those DEXA scans every 5 years, every 3 years? Is it individualized to how concerned you would be?
Yeah, it's individualized. So if I've got somebody with premature menopause who has osteoporosis, then I will aim to repeat their bone scan within a year or two. If they've got normal bones, then we may leave it for 3 to 5 years.
But you'll have seen that on the baseline, won't you? You'll have seen that when you did your baseline scan, which is the reason for doing it.
Absolutely. But I must emphasize that the rate of change is probably even more informative than just doing one bone scan.
Yeah. Okay. That's great. Thank you so much.